Hi, everyone. I'm Angela. We're just going to give people a couple minutes to enter, or a minute to enter. I see that we still have people joining. Okay, we'll go ahead and get started. My name is Angela, and I'm the California and Southwest Regional Advocacy Manager. I want to thank you all for taking time to join us today to discuss advanced care planning. This webinar is being recorded, and afterwards, we're going to send you an email with the recording, and then also with any sort of resources that we mentioned during the call. My hope is that you will share the recording and the resources with your family, your friends, your neighbors. This is all free information that we just want to get out to the community. I want to start by recognizing that April 16th is National Healthcare Decisions Day, and that this is a day to inspire, educate, and empower Americans about the importance of advanced care planning. So in recognition of this day, we're hosting a series of webinars. We had our first webinar last Friday. We did a Spanish advanced healthcare planning. And then we'll be doing webinars almost every week throughout the month of April, and we hope that you will join us. Next slide. So Compassionate Choices is the nation's oldest, largest, and most active nonprofit working to improve care, expand options, and empower everyone to chart their end-of-life journey. We believe in patient-directed care, where the patient is informed of their healthcare options, and they should be in charge of choosing treatments in line with their individual priorities. So this is a quote from Being Mortal. Life is meaningful because it is a story, and in stories matter. So how people want to end their lives. Research has shown us that people want to end their lives at home with their loved ones, with their pain and discomfort managed, to have their spiritual needs and values respected, and without being a devastating burden to their loved ones. In reality, however, 60% of Americans die in acute care facilities and another 20% in nursing homes. 1 in 3 people near the end of life often receive burdensome treatment, which is painful, uncomfortable, and futile, and it often has no hope of improving their health while compromising their quality of life. So I'm hoping that you all have some paper next to you, or if you can use your phone in your notes section. And then what I'd like you to do is we're just going to take about 2 minutes. So find some piece of paper and a pen and think about 5 things that are most important to you at the end of life. I've provided some examples on this slide. So it could be time with your loved ones, being with your pets, being free from pain, not being a burden to your loved ones, being free from anxiety, practicing your spiritual, religious beliefs, having a healthcare team that you trust, to die at home, etc. It can be whatever is most important to you. And I'm going to give everybody about 2 minutes to think about this, write it down, and then we'll move on. But I want to keep this list handy. So hopefully you've had some time to think about this and have written down your 5 things. So it's important to plan for the future. However, before you can make plans for the future, we encourage you to ask yourself some important questions. What are your values and goals in medical treatment? How do you define life? And what matters most to you? What brings you joy? Compassionate Choices, my end of life decisions booklet, is very helpful and can walk you through this process. And you can get this on our website. We have it. You can go on our website and download it and print it, or you can enter your name and address, and we'll send you actually one of these books. And they're really nice. They're about 40 pages long. And what I do and what I've done in the past is I've gotten these books, and my friends and I have sat down and gone through it together just to make it a little bit more fun and think about our advanced care planning together. So death finds us all eventually, and we can't prevent that, but we can direct how we'd like our final days to unfold. Advanced planning is key, making thoughtful choices now, putting them in written advance directives, and discussing these choices with others. Advanced planning helps ensure that we get the care we want at the end of life. An advance directive is a legal document that outlines end of life priorities. So it typically is comprised of two things. One would be a living will, and the other is the medical power of attorney. So living will is more about what the treatment options that you want if you're unable to speak for yourself, if you were to become incapacitated. And then the second part, the medical durable power of attorney, which is sometimes also called like a healthcare proxy. This is who will speak for you. So who's going to talk to the doctor about the treatment options and advocate that you get the care that you want or don't want. It's recommended that everyone over 18 have an advance directive. So there's great disparity between completing advance directives and historically underserved populations. So if you look at this graph, you can see that about 35% of people age 18 and older who are non-Hispanic whites have completed their advance directive. And that's compared to about 12% of African American and 11% Hispanic Latino. When we look at graphs and data closer people who complete this from 50 and over, the numbers look a little bit better. It's about 44% of non-Hispanic whites, 24% African American, and 26% Hispanic Latino. So you can still see that there's great disparity within documenting end of life preferences. So when you look at your living will, these are just typical treatment options to consider, and I wanted to go over them briefly. So artificial ventilation, which is sometimes called mechanical ventilation, is when a person is having difficulty breathing on their own. So a tube can be inserted either through the mouth into their windpipe, or a hole can be made in the throat. And then a machine will push a precise combination of oxygen and air into the person's lungs to help them breathe. So some people are given artificial ventilation and then they're weaned off it. But many others who are given artificial ventilation are unlikely to recover the ability to breathe on their own. The longer a person uses artificial ventilation, the less likely recovery becomes. Medications to stimulate the heart. So if a person has experienced heart failure, they often take medications to regulate how their heart works or restart it if it stops. If somebody is terminally ill, they may want to consider whether or not they want to take their medication to stimulate the heart if it's only to prolong the dying process for them. And then artificial nutrition and hydration. So this is provided for people who cannot swallow sufficient amounts or cannot absorb nutrition through the stomach. For someone who can't swallow, a tube can be inserted through their nose or surgically inserted through their abdominal wall into their stomach. This can provide support for people who have acute illness, but for people near the end of life, this often does not extend life and can cause additional medical problems and increased suffering. Usually it will cause bloating, nausea, and stomach problems. So I want to talk about choosing a healthcare power of attorney. I recently received an email from someone and they had a question about their healthcare power of attorney and said, I don't have any family and I selected a friend to be my power of attorney, and asked, is this okay? Is this a good option? And I responded and told her this is a great option, that when I give these presentations, they usually include a slide about it. So things that you want to consider uh, when choosing a healthcare proxy is, are they assertive? Are they comfortable talking about death? Do they live nearby? Will they respect my decisions? So we'll talk about this a little bit more, but when you fill out your living will, you really should be having these conversations more with your healthcare proxy and talking about what what it is that you really want. What is the medical treatments that you want so that they have a better understanding of, if it's not just this one kind of emergency, what kind of care would you want if they were to make selected to make these decisions for you? So when we look at options, like a lot of times people pick family member or friend, a neighbor, a member of your faith community, a local senior service. Sometimes they have volunteers, sometimes there's elder case managers, and then elder law attorneys can also do it for a small fee. And one of the things that I just wanted to point out why sometimes it's, maybe beneficial to pick a friend is that family members can become overcome by grief during this process, and they may not, you know, because of the grief, they may not choose to honor the wishes that you have laid out for them. I recently had this conversation with my husband when I started working at Compassion and Choices, because he had been listed as my healthcare proxy. And then I realized that I think he would probably do anything he could to keep me here. And that might not be what I wanted. So I switched and I asked one of my best friends, who's a really strong advocate, and she's very assertive, to be my healthcare proxy. And when I talked to him about it, at first he was kind of, not really understanding. And then I asked him, would you honor my wishes if I asked, to be removed from a ventilator? And he was like, well, I don't know, so it's good that we had that conversation, and it's a good thing to consider about who it is. Another thing that people may want to consider when choosing a family member or a friend is sometimes your family members may live in another state. And so sometimes having a friend who's nearby who can get to where you are in a crisis may be a better option as well. So my hope is that everybody has completed their living will who's on this call, but I do want to go over it quickly just so you can see. I live in Arizona. So I pulled our Arizona living will from the Attorney General's office. And so the first page, it just goes over instructions on how to complete the form. And they'll often always tell you who can be a witness and who cannot be a witness. On the second page, at the top, you just enter your information. That middle section there is where you will select what kind of healthcare treatment options you would want. And then that bottom spot, there's usually a part to attach any additional medical information. So you can check if you're attaching more medical information or if you're not. And then on the last page, you'll want to sign it. And in most states, you don't need an attorney or a notary. In Arizona, you can have a witness or a notary. So the important thing here is to remember not to sign it until your witness or the notary is present. And then same thing when you pick your healthcare proxy or your power of attorney, you'll want to make sure that they accept the appointment and that you sign it in front of a witness. So going back to the exercise, if you can pull up the 5 things that are most important to you at the end of life, what I'd like is for you to think about crossing out 2 of them so that only the 3 most important things remain. And then we're going to talk now about charting your wishes beyond the living will and healthcare proxy. So ambulance and hospital emergency department personnel are required to provide CPR unless they're given a separate directive that states otherwise. These directives are called do not resuscitate orders. Some healthcare systems have now started calling them allow natural death. So if you hear that term, that is what it is. It's the same thing as a DNR. So these are designed for people whose poor health gives them little chance of benefiting from CPR. These directives instruct ambulance and hospital emergency personnel not to attempt CPR if your heart or breathing stops. and you should discuss with your doctor whether such an order is appropriate for you. So the Pre-Hospital Medical Care Directive, which is called an out-of-hospital DNR, informs emergency personnel outside of a hospital setting that if you stop breathing or if your heart stops, not to do CPR, use equipment, drugs, or devices to restart your heart or breathing. So an attending physician will not issue an out-of-hospital DNR if the person requesting this order is not eligible for it. So typically, a physician will only do this if a person is terminally ill, extremely elderly or frail, and mentally capable of making such a request. And just as a side note, I often have people tell me that when they do have the out-of-hospital DNR, they put it right on their refrigerator. I have some people tell me they put it on every single door in their house in case something were to happen if they were in their bathroom or guest room or their bedroom. And I even have people tell me that they share this information with their neighbors. That way, if EMS were to come over to somebody's house, the neighbor can alert them and say, oh, they have a DNR. So what you'll want to do is print this form it's usually on orange paper, and just your typical 8.5 by 11 paper, and display it in plain sight in your home. You can also print this in color and have it on wallet size and put it in your wallet. And this form must be signed by you and a licensed healthcare provider with one witness. And so a portable order for life-sustaining treatment, that is the national term for it, and it varies state by state. They're most often called MOLST, which is a medical order for life-sustaining treatment, or sometimes just MOST, M-O-S-T. And this is printed on bright pink paper. So this is a voluntary form with medical orders indicating a patient's wishes regarding treatments commonly used in a medical crisis. This is only for seriously ill or frail patients. And this would be the treatment that a person would want if they were to have a medical crisis like today in their current state of health. So the original post always stays with the patient. So this form is intended to be completed after careful advanced planning with the patient, your family members or people close to you, and your healthcare professionals. And the form must be completed and signed by the healthcare professional accountable for your medical orders. So while the DNR, the orange paper, provides EMS and healthcare not to provide CPR, a post can also include information on CPR, but it also provides additional instructions such as whether or not a person might want to be sent to a hospital or be put on artificial nutrition and hydration. And so at Compassion & Choices on our website, you can also find 3 additional addendums for your advance directive. So one is the Sectarian Healthcare Directive. So this is an addendum to clarify that your wishes supersede those of any institute religious policies, and that you wish to be transferred if a facility refuses to follow the preferences you've outlined in your advance directive. So something I just want to flag for everybody on this call is that a lot of Catholic hospitals, they can provide excellent care, but sometimes they have policies around end of life, and they're, anyone who's employed by that hospital is required to follow those policies. So if, it could be that, they maybe require, artificial nutrition at the end of life. And if that's something that you don't want, you want to make sure that you have the Sectarian Healthcare Directive and that this is outlined that you want to be transferred to a different hospital. And just to let you know, Catholic affiliated hospitals have grown more than 28% over the last 2 decades, even as the number of secular hospitals has dropped by nearly 14%. It's not always easy to tell whether or not a hospital has some sort of religious policies. And in particular, I cover several states. So in one of the states, we have a healthcare system, and it has a, just a basic name, but there's 5 different campuses. And one of the campuses is a Catholic hospital, and has, Mercy is in their name. But the other healthcare sites, you wouldn't necessarily be able to tell. But because they do have the Catholic affiliation with the one campus, none of the other hospitals and healthcare systems can practice the end of life options that are available in that state. Not all of them. So an assisted living facility writer is a contract writer for people who live in assisted living facilities. And so this is something that you would complete before you move into an assisted living facility. And it just confirms that if you want to stay here until you die, that, this assisted living facility is going to ensure that you can have the end of life options that you want. And then a hospital visitation authorization form enables people who are traditionally not recognized as your family to gain priority visitation rights if you're in the hospital. So once completed and signed, these should be kept with your advance directive. And then it's recommended that people also review your advanced care documents when one of the 5 Ds occurs. You can review them as often as you want, but at minimum every decade. So every time you start a new decade, when there's a death in your family, whenever there's a major family change, such as divorce, whenever you receive a new diagnosis, and whenever you experience decline. And whenever you do update your advance directive, what you want to make sure is that you discard your old ones and reach out to your healthcare proxy or anyone who has them, your doctor, and you ask them to also discard those and give them the new ones so that everybody has the same advance directive and it's the most up to date. And then Compassionate Choices has also created a dementia values and priority tool. And this will help you identify personal values and care wishes so that you can stay in control even if dementia takes hold. So this tool helps you provide clear-cut instructions to your loved ones and takes the burden off them so when you can no longer make decisions for yourself. So next week, you should have all gotten the invite, but we'll be reviewing this tool in more detail. And it's just another offer that we have for National Healthcare Decisions Day. So again, the most important part of this is that you cannot do this alone. Not including your family or your loved ones in your planning will definitely leave them with regrets and questions after you die. Not including them will also make it less likely that your plan, whatever it is, will be successful. So it's important to sit down with your family and have this conversation. Our founder often talks about, having this conversation over Thanksgiving dinner. When everybody's gathered together so that everybody's on the same page. And I know sometimes it can be difficult. And just like in my own personal family, when my grandmother passed away, my mom and all her aunts, it turned out my grandmother didn't tell them all the same stuff. She just told my mom because she figured my mom would be the one making the decisions. So things, got pretty hectic at the end of her life. And nobody talked to each other for a year afterwards because nobody had agreed with how things had happened. And, luckily they've all mended, but it can really cause some, like family disruption if you don't have these conversations. But I understand it's sometimes not everybody will agree with it, but sometimes it's just nice to let everyone know what your wishes are. So next, we're going to talk about end-of-life options available in the United States. So researchers at Stanford University studied whether doctors and patients attach different meanings to the word treatable. Researchers found that when patients hear the word treatable, they have a positive message about the future. They hear that the disease can be cured or at least contained, so that it does not seriously diminish their quality of life. If their doctor also shares dire news about the overall prognosis, patients tend to discount this and only come away with the good news of treatment. However, the study revealed that doctors mean something quite different when they say treatable. Doctors say treatable when they don't want to use the word incurable. When doctors say the treatable, they simply mean that there's treatment available for this. Doctors don't mean to imply that treatment is likely to succeed or that if it does succeed, the disease will go away. They don't even mean that it can prolong life. The chance of a treatment option could prolong life might be very small, and a doctor can still use the word treatable. Researchers concluded that when physicians use the word treatable, This leads patients or their loved ones to derive unwarranted good news and false hope to pursue treatment, even when physicians have explicitly stated information to the contrary. So this very unfortunate confusion over the word treatable is avoidable. Numerous studies suggest that patients and their loved ones prefer candor from their doctors and often over vague terms that lead to false hope. People want to make plans and treatment decisions knowing realistic benefits, burdens, and full risk of their treatment. So end-of-life options available in the United States. So you can always pursue life-sustaining treatment. Palliative care, which is also called symptom management, focuses on pain management and comfort care. You don't need to have a terminal prognosis to receive palliative care. So palliative care can be used to treat either the disease itself or symptoms of side effects of treatment. So it can be if you have cancer and you're receiving chemotherapy, you can and it causes nausea sometimes. You can receive palliative care to treat the nausea from that. And then palliative care is available in medical and assisted living settings and in the home. Hospice is a service that provides compassionate medical care at the end of life. So to be eligible for hospice, the patient has to have a terminal illness and their doctor has to determine that they have 6 months or less to live. The goal of hospice is you would stop treatment, but the goal is to maintain and improve quality of life. There's an interdisciplinary team that usually consists of doctors, nurses, social workers, home health aides, hospice chaplains, and trained volunteers. For those who have an appropriate medical referral, Medicare, Medicaid, and usually third-party insurance will cover hospice. And then hospice also can be provided to people wherever the person resides. So it can be, in the hospital, but most often it's provided in the home. And then hospice also offers additional benefits to the family. It can provide end-of-life planning and then also bereavement counseling for the family. So the major difference, just to clarify, because sometimes people get confused over palliative care and hospice, is palliative care, there does not need to be a terminal diagnosis or a terminal prognosis. With hospice, you do have to have the terminal prognosis with 6 months or less to live. So palliative sedation, which is sometimes also referred to as terminal sedation, is an end-of-life option that is practiced in very rare circumstances. This is for people whose symptoms and pain cannot be managed while conscious. Palliative sedation must be medically managed and is only provided after your doctor talks with you and your family before starting this process. So the sedating medications can be given to the patient in several ways. It's most often in the form of IV, and most people pass away within a few days, a week after starting this process. And then refusing treatment. So you can always refuse treatment and you can request comfort care. So for example, if you have cancer, you don't have to do chemotherapy, or if you have pneumonia, you don't have to take the antibiotics for it. And the last two options are voluntary stop eating and drinking. The acronym for that is VSED, and then medical aid in dying. And I'm going to talk about those in more detail in the next couple slides. So voluntary stop eating and drinking is when a mentally capable individual decides to take control of their dying by making a conscious decision to refuse foods and fluids of any kind, including artificial nutrition and hydration. So VSED can be sought at home or in a care facility, but it should be medically managed to minimize discomfort. It's not recommended that somebody tries to do this alone. You will need 24-hour care during this process and ongoing hospice care or oversight by a physician. And I had somebody reach out to me one of the last times I presented about voluntary stop eating and drinking and ask when I said you will need 24-hour care if that meant that they had to go into the hospital for 24-hour care. And I just want to clarify that this just means, usually people will have their family members with them, or I've had people, that all of their friends will come and take shifts sitting with them just so they can help them stay comfortable during this time. So voluntary stop eating and drinking is legal in all states. However, not everyone is understanding and supportive of this choice. If you reside in a care facility, discuss your wishes with the nurse or the social worker. You will need their agreement to support you. Sometimes what we recommend too is that when you are having this conversation with your healthcare staff, that you let them know, I understand that you're medically that bound by ethics to give me food and water if I request it. But what would be helpful is if, I make this request that you give me a gentle reminder that I was doing voluntary stop eating and drinking. So sometimes what this looks like is, if a person wakes up and, their nurse comes in and they say, oh, I just had this dream that I was eating this big breakfast and I'd really like some bacon and eggs. The nurse can say to you, I'm happy to get you some bacon and eggs, but I just want to remind you that you're doing voluntary stop eating and drinking. Is that still what you want to do? And then again, as a person, you make the decision, yes, I want to keep doing voluntary stop eating and drinking. Or sometimes people will say like, no, I do want to eat. So when choosing voluntary stop eating and drinking, it can be difficult to predict exactly when the end will come. So this can depend on the person's physical condition, their age, medications, the illness, height to weight ratio, fluid retention, ability to remain completely free of all fluids, and then sometimes maybe just a person's ability to let go. For a terminally ill person, this process may take several days to several weeks. Some people experience complete unconsciousness in as little as 2 to 3 days. So since the length of process is unpredictable, planning ways to bring meaning, pleasure, and comfort during this time may reduce anxiety about the length of the process. So dying patients may want to choose a favorite movie, music, poetry, and passages to read or have read to them. They may want to share memories or favorite stories with photo albums and scrapbooks. Keep a journal in the form of written or video or audio. Create some type of legacy project to leave behind for their loved ones. And they may also want to ask their caregiver to apply body lotion and keep the hands and skin hydrated. So medical aid in dying is authorized in 11 jurisdictions. And so this is when an eligible terminally ill person is able to receive medication, a prescription for medication to peacefully end their suffering. So medical aid in dying is authorized in 10 states, which are in blue on this map. So California, Colorado, Hawaii, Maine, Montana, New Jersey, New Mexico, Oregon, Vermont, Washington, and then Washington, D.C. as well. So currently over 5 Americans have access to this. Sorry, 1 in 5 Americans have access to this. So each state passes their own law, so they vary slightly. I would say most often they vary in like the length of time. So it typically requires that you make 2 requests to your doctors. And so in some states, like New Mexico, you make your first request and then you can make your second request within 48 hours. But then in other states, it may take, you can make your first request and then I think the longest that we're working on changing right now, it's there's a 20-day wait in Hawaii before you can make your second request. But the eligibility requirements are basically the same in every state then. So a person has to be 18 years or older, terminally ill with a 6-month or less to live prognosis. And so that's the same as hospice. And then capable of making medical decisions and have the ability to self-ingest. So it's really important to talk with your doctor about your end of life options, and Medicare will allow reimbursement for advanced care planning conversations and direct communication with your healthcare providers regarding end of life care. So if you're considering that you may want to choose voluntary stop eating and drinking or medical aid in dying if you reside in a state where it's authorized, we encourage you to speak with your doctor about these end of life options. You don't have to wait until you have a terminal illness to have these conversations. We encourage people to do it as soon as possible. because you want to make sure that your doctor supports you or that you have time to find a doctor who supports you, because it's much easier doing that when you're healthy rather than waiting until you have a terminal illness and then trying to make sure you have the support of your doctor. So one of the issues that we do try to educate the public about is that physicians also have legal rights and they do not have to support you in these options. So you don't need the approval from your doctor to do voluntary stop eating and drinking. However, the support from your physician and enrollment in a supportive hospice will greatly increase the patient's comfort, as well as help ensure that your wishes are respected. In states where medical aid in dying is authorized, you may find that your physician is supportive, but the healthcare system has policies that prohibit them from participating in this because they've opted out of this end of life option. So again, this is more common with religious healthcare systems, specifically if it's the Catholic healthcare system. So we really want people to spend their last few weeks or months, saying their goodbyes to their family and having quality time with their loved ones, rather than trying to navigate a complicated healthcare system. You may also find that your doctor is willing to support you in this end of life option, but they're unfamiliar with the process. So if this is the case where your doctor is willing and the healthcare system is able, but they've just never gone through this process, we have a resource for that again, I'll send out in the email. And it's called our Doc to Doc phone line. And so this Doc to Doc phone line is answered by our national doctors who specialize in end of life care. And it's free and confidential. And they basically will just mentor your doctor through the process. If you do receive a terminal prognosis and request medical aid in dying, make sure that your doctor documents your request. I want to repeat that. So if you do receive a terminal prognosis and request medical aid in dying, make sure that your doctor documents your request in your medical records. So as I stated before, you have to make this request to two different doctors. So that first request that they document in your medical records would be your first request. So you want to make sure that's documented, because we have had it, unfortunately, where people have reached out to us, they thought their doctor was on board, only to find out later that, my version of support me in this process and my doctor's version of support me in this process were very different, and they weren't really willing at all to support me at using medical aid in dying. We also recommend that if this is the option that you want to choose, that you be very clear and say that you want to do medical aid in dying. Use those words specifically so that there's no room for, different interpretation of what you want for your end of life options. Another resource that we offer is how to interview a hospice. And so while most hospice offer the same basic services, not all hospices are the same. So on here, I've just listed some of the end of life option questions around how to interview a hospice. And so we encourage you to call and interview hospices in advance, similar to finding, a doctor to support you, so that you can find the hospice that best aligns with your values, priorities, and beliefs. So these are just a couple questions again on end of life options, but there's other questions on there such as, what is the role of my physician once hospice care begins? Can I still see my doctor if I want to? Some other questions you might want to ask is, is there 24-hour care provided? How many, staff to patient ratio do you have? So again, it's a really great resource that we'll send out, and we just encourage you to have these conversations with hospices ahead of time. So going back to the exercise, if you can find the piece of paper that you wrote the 5 things down, and then cross out 2 of them so that you have 1 thing left remaining. And what I would like to ask is that if you can put in the Q&A section, if you're willing, to share what the one most important thing remaining is for you. So I'm just going to read off a couple of these. So somebody said, my cat, to remain calm, to be free from pain, time with family, free from pain, comfort, no pain, to be at home, being free from pain, die my way as much as possible. A lot more free from pain too. Ability to care for myself, having no pain, anxiety, and so serenity, acceptance of the dying process, to die peacefully. And one of the reasons I like to do this exercise is because I think it shows that people have different things that are most important to them. I have 2 cats and 2 dogs, and I love them so much, and I want them to be with me. And but I think it's a lot of times people assume that what is most important to me is also most important to you. Or they think I think I know my friend well enough to know what is most important to them without them telling me, right? So I did this exercise with some of my friends, and one of my friends had a baby. He's about 1 now, and she just wants to be with him all the time, right? And so when we did this exercise, I thought that she was going to say she would want her family to be with her, like in particular her baby. And what she actually said, which really surprised me, was that she did not want to be a burden to her family. That was her number one goal. I never, never, ever would have guessed that about her. So it's really important to have these conversations again with your friends and your family and your doctor, because we can make our best guesses about what you want for your end of life care, but we don't know unless you tell us. So then just some key takeaways for this is we hope that you can identify what is most important to you. And we hope that you understand that it's important to document your wishes. Make sure too, when you document your wishes, that you don't keep them in a security deposit box or any sort of other safety box where nobody can get to them. Make sure everybody has access to them. Talk to your family, friends, and support system about your end of life wishes. And then again, April 16th is National Healthcare Decisions Day. And if you haven't already sat down and gone through all of this with your family and friends, we encourage you to do this on April 16th. One of my coworkers actually reached out when we sent out this email and told me that she's going through this process with one of her parents, and that they had actually filled out all of the advanced directives quite some time ago, but they have never actually sat down and really had the conversation about it. And that getting the email from me saying, inviting everybody to these webinars really encouraged her to start having these conversations. And then I want to also just go over some additional resources that Compassion and Choices has. So nearly 70% of Americans don't have an updated legal will, and everyone is encouraged to have an estate plan, regardless of, how much finances you have or what you own. And so Compassion and Choices has partnered with Free Will, which is an online will writing service to ensure that our entire community has access. And this, I'll send out this link in the email as well, but Free Will takes about 20 minutes or less to complete. And then some other resources that we can send you is finding a partner doc. So this is just a little tiny palm card that we encourage you to make a standalone appointment with your doctor to talk about end of life care. And it just prompts some questions that you might want to ask your doctor. And then I mentioned before that we have the doc to doc line. And so that is any doctor can call this line and get free and confidential information about all end of life care options. So if you talk to your doctor about voluntary stop eating and drinking and they're not familiar, they can call this line. And then the same phone number on here. So if you push 1, you go to our end of life consultants. And if you push 2, you go to the doc to doc line. So I'll send out the end of life consultant information in the email as well. But that's just a resource for anybody in the country. You can call it, or if you're caring for somebody else and you want to find out some information, we have end of life consultants that are familiar with resources and information in all the states. And they just provide information and education about all end-of-life options, where to get your advanced directives, how to navigate a healthcare system, um, whatever kind of, they're amazing. Whatever kind of questions you have, they will help you with. And then we also have some more resources. I'll send this out. So we have what we call the diagnosis decoder. And so this will help you come up with questions to ask your doctor to make sure that you can get the care that you want. We have one for dementia, one for cancer, and one for general illness. And these will just populate a list of questions for you to ask the doctor. So if your doctor says, you know, I want you to go get this test and it seems like it might be a little invasive to you, it just encourages you to have that conversation with your doctor and say, you know, I'm not really interested in getting that specific test done. Is there other ways that we can get this information? You know, if quality of life is more important to you than quantity of life, then say like, is this test really needed? Is it going to improve my quality of life? If quantity of life is more important than quality, you know, making sure that your doctor understands that and letting them know, like, when you have these conversations with your doctor saying like, my goal is to live as long as possible. What are the treatment options that you can give me? Just being clear and asking your doctor so that you can get the care that you want. And then we also have a webinar series. So it's called Staying Stronger Together. And I'll send the link out with the email. And here you can just go on and we have just a whole bunch of webinars around end of life that you can watch that have been recorded from that we've done in the past, just free whenever you have time. And I just wanted to share, in case you weren't familiar, so we really count on our volunteers to help support our vision for expanding options at the end of life. So if you're interested in volunteering and you haven't done so yet, you can go to compassionandchoices.org/volunteer and sign up to be a volunteer. We have volunteers in all states. And they can go out and, you know, drop off literature to different senior centers or give presentations, host book clubs, a whole variety of things. Whatever kind of your skill set is, we try to match and capitalize on that. And then you can always help by supporting our vision. So we're funded almost exclusively by individual donors who are committed to issues of end of life. With sufficient resources, we can realize end-of-life options in every state. Every donation of any amount makes a difference. Please consider making a donation today at compassionandchoices.org/donate. And now we are going to have some time for questions. And I have asked my coworker, Leslie, to join us. She's been monitoring the Q&A section.
Yeah, hi everyone. So I am going to read out some of the questions. So one of the questions was, where can I find the book? Which I think is the one that Angela talked about in the beginning, being Mortal. You can find that on Amazon, Audible. So you can find that there. And we can also send a link to it in the follow-up email that Angela is going to send out. Where are these documents? So like I said, the resources that Angela went over, she will send out in that follow-up email. So you will have a link to all the resources that Angela just went over. And then we also have a question that says, if somebody moves states, is it best for them to obtain new advance directives for that state, or are they honored across state lines? So it is recommended that you fill out a new advanced care directive for the state that you move to, because one state's advanced directive doesn't always work in another state. Some do honor advanced directives from another state, but some don't. So it would be best to fill out a new one from your state. And we also have one that says, is doc-to-doc free? So yes, our doc-to-doc program is completely free, and all of our resources are free on our website as well. And Angela, I'm going to kick one question over to you. So we have a question that says, is it common or easy for another physician in the group practice or system to be the consulting physician? or do you have to go become a new patient with a new doctor?
No, you don't have to. The initial doctor will be the doctor that's caring for you. So they're the prescribing doctor. The consulting physician is just a second opinion, and they're basically just verifying that you have a terminal diagnosis and prognosis of less than 6 months or less to live. And so what we have found is that doctors, when you're in medical school, there's not like doctors have to learn so much, right? And so sometimes end of life options is not the most discussed unless that's specifically what they're focused on. But especially medical aid in dying. So every time we're introducing legislation in new states, doctors that have already been practicing in these states may not be familiar with medical aid in dying. And so what we have found is that making sure that your prescribing doctor, usually again, it's the doctor that you've been seeing for your treatment all along, that, what they get a little nervous about is that, they've never gone through this process before, which is why we have the doc-to-doc line. So finding that first doctor is usually the most challenging piece of this. And like I said, we have the end of life consultation line that you can call, and they'll try to help you go through that process. But usually finding the consulting physician is a lot easier. So that's that second doctor. So usually the most important thing that's going to be one of your biggest hurdles is finding that first doctor. And I also just want to clarify, because I realized I didn't, when we talk about the process of medical aid in dying, I mean, in the ideal world, it can take a couple of days for you to make the request and then for you to get the medication. But it is a compound medication. And so even in states, though, like California, if you live in California, we recently changed the law in California. So instead of being 15 days, it's now 48 hours. There are a lot of healthcare systems that will participate in this process, but because it's a compound medication, that whole process of asking your doctor and going through it takes a minimum usually of about 3 weeks with one of the healthcare systems in California. So just because it's a 48-hour waiting line doesn't mean that you'll, make the request and within 48 hours, you have your medication and everything's ready to go. So again, we just encourage people to plan ahead. And if you need help, again, I'll send out the end of life consultation line. We have in the past tried to keep track of, which doctors and healthcare systems are participating in this option. But it just became pretty difficult for us to keep track because, doctors leave and go to different facilities and, different healthcare systems get bought out by other healthcare systems. But we do kind of have like a generic list that we try to work from, but we also, again, they'll encourage you to call and verify that that doctor is still there and that they still provide this option for you. One of the other questions on here that I saw, sorry, I was reading through them, is if I have dementia, can I use medical aid in dying? So for medical aid in dying, you have to have a terminal prognosis of 6 months or less to live. So if your diagnosis is, and you have to be mentally capable of making the decision at the time when you take your medical aid in dying. So you can die from Alzheimer's disease and other forms of dementia, but that usually takes several years before you get to that point. And by the time you get to that point, you won't have your full decision-making capabilities. So that wouldn't be an option at that point. However, if you have a diagnosis of dementia and it's recent, and you still have all your full mental capacity and you're making all your healthcare decisions still, and then you also have a different terminal illness that has a prognosis of less than 6 months, again, as long as you still have full decision-making capability, then you could still request medical aid in dying. And another question is, can I just move to a state that offers medical aid in dying when my time comes? And so most states have a residency requirement. Yeah, last year it was. We have a legal department at Compassion and Choices, and they were part of a lawsuit in Oregon. And part of the settlement required we won the settlement. So part of the settlement required that the Oregon state legislation or the state legislature had to remove the residency requirements in Oregon. Primarily, this was because Portland and Seattle are so close. So there's a doctor in Portland who had patients in Seattle, and medical aid in dying is authorized in both Oregon and Washington, but he wasn't able to prescribe to his patients in Seattle. But this has opened it up so that you don't have to be a resident of Oregon to use medical aid in dying. So while we think that this is a good option, we still know that people want to die at home. And so, it can also be difficult if you're terminally ill in your last 6 months of life to travel to another state and up and move your whole life. So we're still working on trying to pass medical aid in dying in several states currently, and still working on just, letting people know what their end of life options are, so that they can make the best decision that aligns with their own values. Do we have any other questions, Leslie?
Yeah, we have a few more. So one was more of a comment, but I don't see where the next events are posted. I didn't get an email for any future event. And Angela, I think in the follow-up email, you'll send out links, right, to the national webinars?
Yes, I will send out links. If you Google Compassion and Choices events, that will take you to our events page. And you just scroll down a little bit on the page, and you'll see all the events that we're having. We're actually having an event tomorrow. I'm not putting this one on, but tomorrow's National Doctors Day. And so they are going to be talking about end of life care options. I think Rebecca maybe is interviewing 4 doctors, and they're just going to share their experience with helping their patients through their end of life care. And then, but next Wednesday at 12 Pacific time, we're going to do the dementia training. So we're going to go over the dementia values and priorities tool, and then also the dementia decoder. So I'm just going to walk people through how to use it, how to best use it as a tool for you. And you can register for that event. Again, just Google Compassion and Choices events, and our events page should pop up. I'll send it out in an email, but just if you want to get started and register ahead of time, you can do that. And then we're also going to be doing one on April, I think it's 13th at 4 p.m. Pacific time, perspectives from end of life doulas, and how they can add value to your end of life care. And then we're going to do another one on April 27th at 4 p.m., which I think will be fun. There are 2 women in LA who created what's called the Death Deck. And they're just these cards, and it's a game that you play basically, and there's humor within it, but it's just it's a card game to basically get the conversation started around talking about death. And then we also have another partner that's going to be joining us, and she hosts what she calls Death Over Drafts. So again, just trying to, one of the reasons why the advanced care planning, those numbers were so low, is because people don't necessarily want to talk about death. So we're trying to find more fun ways to discuss death, because it is really important. Like, if you live this great, amazing life, we want to make sure that your death matches that. So we have 1 more minute. Do you have anything quick, Leslie?
We have a few, but I know there's one that said, how recently has Compassion Choices updated their documents? I know our team updates our website pretty frequently, especially as we introduce legislation or anything changes. They update our website as soon as they can.
Yeah, this booklet that I have, I just looked at the back and it says April 2022. So again, if you want more documents or information, when we send out the email, just respond to it and let us know, and we can work on getting you this booklet if you want us to send it to you. Or again, we'll send out the link so you can just go in and enter your name and address and get it delivered to you. So, all right. Well, I want to thank you all for taking the time to join us today. I hope it was helpful. And then I look forward to seeing some of you next week. Thank you.